Good day, my dear friends. I'm sorry it was technical problems with internet. Let's start today's lecture. Please write who are present, and listen me. Do you listen me or no? Please write. I wait. Okay, I see. Students present lecture. Okay, let's start. Today's topic, disseminated forms of tuberculosis. Disseminated tuberculosis of the lungs units the processes of various origins developed as a result of proliferation of Mycobacterium tuberculosis, hematogenous, bronchogenic, and lymphogenous ways. What has caused a variety of clinical and radiological manifestations. Disseminated tuberculosis of the lungs is divided into three forms. First, acute, or other name of this form, miliary TB, subacute tuberculosis, and chronic disseminated tuberculosis. On this photo, you can see TB dissemination in the lungs. White dots, it is lesions of the lungs. TB etiology. I see many students are present. It's very good. Next, first form of dissemination, name miliary tuberculosis. Miliary tuberculosis, or millet, is characterized by an acute and repeat dissemination. It is the generalized process with involvement lungs, liver, spleen, intestine, meninges, and other organs and tissues. Lesions looks like on millet grain, therefore this form name miliary TB. Miliary tuberculosis is primary as a complication of primary tuberculosis in children, and secondary as hematogenous dissemination of foci of tuberculosis infection, especially in immune deficiency, more common in HIV-infected persons. That's why this form can be primary, but more often form as secondary form of TB. It's a result of endogenous reactivation of all changes inside of organism. More often can form after primary TB, tuberculosis of intrathoracic lymph nodes, and primary tuberculosis complex. There are four clinical forms of miliary tuberculosis. First, name pulmonary form. Second, meningeal form. Third, typhoid. And fourth, acute miliary sepsis. On this macro preparation, you can see lung tissue affected small monomorphic lesions up to 2 millimeters in diameter. The pulmonary form of miliary tuberculosis. Sudden dyspnea, pallor, cyanosis, tachycardia, violation of gas exchange in the alveoli, dry cough, nasal lesions of the bronchi, pain in the chest when breathing, lesion of the pleura characterly, moderately expressed intoxication syndrome, and negative tuberculin skin test is characterly for miliary tuberculosis because miliary tuberculosis can form in a patients with low immunity. Therefore, antibodies are not formed and Mantoux test is negative. And negative tuberculin skin test in this form of TB is very bad prognosis for patients because specific immunity, specific antibodies against mycobacteriums of tuberculosis is not formed. On this photo, you can see macro preparation. The pleura of the lung affected millet pockets. Next form of miliary tuberculosis, intoxication form. Febrile fever, chills, sweats, pallor, tachycardia, toxic defeat of the central and peripheral nervous system, shortness of breath, impaired gas exchange, toxic blood and urine, damage to liver and kidney, tuberculin energy. That's why Mantoux test is negative. Moderate to marked pulmonary syndrome. Tuberculous meningoencephalitis is variant of miliary tuberculosis, characterized by lesions of the central nervous system, most often develops in patients co-infection, HIV, and TB. Expressed meningeal syndrome, pathologically altered indicators of liquor, moderately expressed intoxication syndrome is characterly for tuberculous meningoencephalitis. Next variant of miliary tuberculosis, tuberculous sepsis. Can develop in patients with co-infection more often, co-infection HIV-TB, characterized by a septic condition, but not pronounced intoxication and pulmonary syndromes due to the small number of immunocompetent cell elements. On this photo, you can see patient co-infected AIDS and tuberculosis. This is last stage of HIV infection. characteristic X-ray pattern appears only at 10-12 days after onset of clinical manifestations. During these days, we can see on X-ray only severe lung pattern and cannot see focal shadows. This poses a significant diagnostic difficulties in the initial period of the disease, the incorrect treatment tactics, the potential adverse outcome of the disease, especially in children. This is great role of the radiologist in the diagnostics of miliary tuberculosis. And on X-ray, in miliary tuberculosis, we can see a symptom of dissemination, and we can see many small focal shadows. Shadows, what characteristic of these shadows? First of all shadows are same in density, because this form of TB is a generalized form as a result of hematogenous dissemination. Therefore, changes can form same time, and we can see focal shadows same in density. Also, all focal shadows same in size. Sizes of focal shadows in this form from 1 to 3 millimeters, not more than 3 millimeters, usually up to 2 millimeters. That's why same in size, same in density, focal shadows. And for this form, localization of process is typical. Focal shadows localized symmetrically in both lungs. That's why in symmetrical parts, same quantity of foci, and localized uniform. That's why in all zones and fields, same quantity of shadows also. That's why for the main X-ray characteristic, the main X-ray signs are typical for miliary TB. First, shadows small in size. Second, shadows same in density, soft shadows. Third sign, localization is symmetrical, and fourth, localization is uniform. On this X-ray, you can see miliary tuberculosis also symmetrically uniform localization, and shadows small in size and same in density. On this X-ray, you can see miliary TB also. Many small focal shadows, small in density, so small in size, so same in density, soft, symmetrical localization, and uniform localization of shadows, focal shadows. The same. On this X-ray, we can see miliary dissemination also. Better to see changes on CT scan. Here we can see small focal shadows in all fields, all zones, also small and same in density. On this tomography, this layer, in this layer, in tomography, CT scan, we can see many small focal shadows in both lungs and complication exudate in the pleural cavity of right side. That's why this is miliary tuberculosis complicated by pleurisy. Next, sorry. Next form of the disseminated tuberculosis named subacute dissemination. The infection spreads from, in this form of tuberculosis, the infection spreads from intrathoracic lymph nodes, hematogenous, lymphogenous way. That's why for this form, mixed way of spreading is more typical. They result in polymorphic lesions up to 1 centimeter in diameter, localized in the previously in upper and middle parts of the lungs. In the upper parts of the lungs can occur thin caverns. Other name of this cavern, stamped caverns. This is caverns with very thin wall. Therefore, caverns have correct shape, oval or round shape. This form of tuberculosis start gradually, flows in waves. The first manifestations of the disease can be mild shortness of breath, cough with a small amount of mucus purulent sputum, and hemoptysis. General condition of the patient remains satisfactory. There is a good tolerability and low-grade febrile temperature. That's why this form of TB can wear mask of other diseases, other inflammatory diseases of the lungs. For example, bronchitis or not severe pneumonia. And on X-ray, we can see symptom of dissemination also, but focal shadows different in density, different in size. That's why it is polymorphic lesions. We can see soft focal shadows and we can see shadows of middle density. But fibrosis and calcification are absent in this form of TB, is not typical for subacute dissemination. And shadows can be small, focal shadows can be small, middle, or large focal shadows of different sizes. Focal shadows localized previously in upper fields and middle fields. That's why in upper parts of the lungs. Lower parts can be affected less. And localized, not symmetrical and not uniform. On this X-ray, you can see focal shadows in upper parts of lungs, lower parts not affected, less affected. Sorry. And in the right lung, in upper field of right lung, you can see stamped cavina. This is ring shade shadow with thin wall. On this X-ray, we can see many focal shadows also. Foci localized previously in upper and middle fields of different sizes, different density. We can see very soft shadows. Density of these shadows less than density of ribs, and can see more dense focal shadows. Density of these shadows looks like on this density of ribs. That's why shadow changes in the lungs in this form of tuberculosis can form in different times, therefore have different density. And you can see focal shadows can join together in infiltrates. This is not typical for miliary TB, but typical for subacute disseminated tuberculosis. On this X-ray, you can see groups of focal shadows fused together, focal shadows, and form infiltrates. Symmetry absent, uniform absent. And on apex, we can see apex of right lung, we can see cavity of destruction. This is destruction of lung tissue and formation of cavina. On this X-ray, we can see subacute dissemination, also polymorphic lesions. On this X-ray, we can see symptom of dissemination, subacute dissemination, and this form of TB complicated by pleurisy. In the left side, we can see hydrothorax in lower part of the chest. This is fluid in the pleural cavity as complication of disseminated subacute dissemination. On this X-ray, we can see subacute dissemination also, and you can see left lung affected more than right lung. This is not symmetrical localization of focal shadows. As a result of hematogenous dissemination. Result of lymphogenous dissemination, yes. for confirmation of destruction in the lungs, for confirmation of cavities, we used tomography, simple tomography, linear tomography, or CT scan. And on this tomogram, you can see cavina, empty cavina without contents, with very, very thin wall. Cavina has this cavina has correct shade because wall of cavina is thin and not deformed cavina. And around of this cavina we can see many focal shadows of different density. CT scan. In this layer on CT scan, we can see many focal shadows also joined together, fused together in group, and form formation of infiltrate as a result of fusion of shadows. On this layer, in this layer, we can see affection of both lungs. Also, many focal shadows of different sizes, different density. In the left side, fused together in groups, in infiltrates. In the right side, we can see infiltrate with destruction inside. This is formation of cavina. And around of infiltrate many focal shadows. Symptom of dissemination on CT scan also many focal shadows in both sides fused together in infiltrates. On this layer we can see right side is affected more than left side, and we see focal shadows and ring shadow. This is formation of cavina as a result of destruction. Cavina has thin walls and perifocal inflammation around of cavina. Next type of disseminated tuberculosis, named chronic dissemination. Develops from subacute if during the year the treatment is not effective. This form can affect various organs as a result of dissemination. And pulmonary syndrome is always present. Intoxication and pulmonary aggravate by an exacerbation of the tuberculosis process. That's why duration of this form of TB is chronic. Periods of remission can change to periods of manifestation, exacerbation. And during this form of TB, can develop pulmonary heart disease. X-ray revealed polymorphic foci, more dense, localized in the upper divisions of lungs. It can form a cavity in one or both lungs. It's determined by the deformed lung pattern due to the fibrosis, bronchiectasis, and emphysema. On X-ray, in this form of tuberculosis, we can see symptom of dissemination also. But you can see difference between this form of TB and forms before. I mean chronic, subacute and miliary dissemination. In chronic disseminated tuberculosis, on X-ray we can see many focal shadows previously in upper parts of the lungs. Focal shadows different in density, different in size, and can form fibrous focal shadows and calcified focal shadows. On this X-ray, we can see calcification, many calcified focal shadows, and can see soft focal shadows. That's why this is period of exacerbation, because appear new soft foci, and shadows localized in upper parts, and you can see around of focal shadows, especially in the left side, formation of pneumosclerosis. In lower parts of the lung, less shadows, and we can see deformation of lung pattern in both sides and shift mediastinum to the upper. Left hemithorax on this X-ray decrease in size, less than right hemithorax, as a result of formation of connective tissue, as a result of pneumosclerosis. This is chronic process. Therefore, lung tissue can change to connective tissue. On this X-ray, chronic disseminated TB also, and we can see many focal shadows in both sides. More in the left side, deformation of lung pattern, especially in right side, and pleural sclerosis as a complication of pleurisy, TB pleurisy. And in the right side, we can see in lower part of the chest, we can see calcification of pleura. On this X-ray, also many focal shadows of different density, different sizes, more in upper parts of lungs. Heart shadow shift to the upper and shift to the right side on this X-ray. And this symptom name symptom of weeping willow. In lower parts of lung, we can see recurrent emphysema. If one part change to connective tissue of lung, other parts can in other parts of lungs can form emphysema. On CT scan in chronic disseminated tuberculosis, we can see a stem cavernous with thin, thick wall. You can see cavernous have irregular shaped because thick wall, fibrosis around of caverna can deform these cavities. In the right side, you can see bean-shaped caverna This is result of a chronic process. And we should differentiate disseminated tuberculosis with other diseases. This is diseases in which can present symptom of dissemination on X-ray. First, differentiation with pneumoconiosis. This is occupational disease. On this macro preparation, we can see anthracosis. Lung and mediastinal lymph nodes are affected with dust. And on X-ray, we can see the presence of silica dust under the shell of the lymph node, and can see many focal shadows in the lungs. But you can see shadows localized previously in the middle parts of the lungs and lower parts of the lungs and near lung roots. Upper parts can affect it less in this disease. On tomography, in silicosis, we can see the presence of silica dust under the shell of the lymph nodes. In both sides, lymph nodes in the both sides are affected by dust, with dust. Sorry. For this disease, it must be professional anamnesis. Next disease for differential diagnosis with disseminated tuberculosis, named sarcoidosis. On this X-ray, you can see first stage of sarcoidosis. Increased lymph nodes are the roots of the lungs. This is symptom of butterfly. This stage of sarcoidosis, we should differentiate it with primary tuberculosis, with tuberculosis of intrathoracic lymph nodes. But next stage, second stage of sarcoidosis, we should differentiate it with disseminated processes in the lungs, especially with miliary tuberculosis. In this stage, sarcoidosis very looks like on miliary tuberculosis. We can see small focal shadows in both lungs also. This is symptom dissemination. And third stage of sarcoidosis, we can differentiate it with subacute dissemination, because in this stage on X-ray we can see many focal shadows, symptom of dissemination. That's why shadows in both sides, and we can see enlargement lymph nodes in the lung roots. This is picture can be like on subacute disseminated tuberculosis. Therefore, we should differentiate these diseases. Next disease for differential diagnostic name cystic lung hyperplasia. On X-ray in this disease we can see symptom of dissemination, looks like on dissemination with multiple cavities. But on CT scan, we see many cysts with very, very thin walls. That's why for differentiation, of disseminated TB and cystic lung hyperplasia, better to use CT scan. This method is more informative for differential diagnosis. And on CT scan in cystic lung hyperplasia, we can see multiple cavities, giant and small cavities. Next disease for differentiation, congestive lung. On X-ray in this disease, in this problem, we can see affection of heart, and we can see severe lung pattern. This problem can be like on miliary tuberculosis, because in beginning of miliary TB we can see severe lung pattern also, and we should differentiate this problem with miliary tuberculosis. This is also congestive lung. Can be like on dissemination. Next disease, histiocytosis. On X-ray, you can see symptom of dissemination. Looks like on dissemination. But on CT scan, we can see many cavities, multiple cavities of different sizes. Therefore, for differentiation, better to use CT scan also, then X-ray. This method is more informative for differentiation. Next disease, alveolitis of the lungs. You can see allergic alveolitis on CT scan, and lesion of the lung tissue looks like on dissemination with many cavities of destruction. Fibrosing alveolitis, idiopathic fibrosing alveolitis looks like on dissemination also, but only on X-ray. On CT scan, we can see cell lung. Fibrosis, lung tissue change to connective tissue and form fibrosis, and many small cavities in the lung on this form. On X-ray looks like on dissemination. Next, disease for differentiation, canceromatosis of the lungs. On X-ray in this disease, we can see many focal shadows. This is multiple metastasis, but can be like on dissemination. On CT scan, in this disease, in canceromatosis, we can see many focal shadows of different sizes, but shadows are more density, more dense, and have clear regular borders. And this symptom of coins, metallic coins, because looks like on coins. And for confirmation of canceromatosis, we should find the main tumor. therefore use different methods of investigation for confirmation of cancer. For example, we can do ultrasound investigation or CT scan investigation of abdominal cavity or pelvic organs, and can find the main tumor. It will be confirmation of diagnosis. Other methods for confirmation of diagnosis: video bronchoscopy or video thoracoscopy with biopsy. More detail about these methods. Video bronchoscopy with biopsy of lung tissue is performed through the bronchoscope under the control of fluoroscopy and ultrasound apparatus. On this photo, you can see biopsy in video bronchoscopy. Material from bronchus, from lungs, we should investigate it, do histological investigation, and if we found giant Langerhans cells in this method, we can confirm tuberculosis. Next, video thoracoscopy, next method of differential diagnosis of examination with biopsy of lung tissue is conducted through thoracoscopy. And on the low photo right side, you can see tuberculous lesions under the pleura. Also, we used operative biopsy of lung tissue after operation, after resection of the different parts of lungs. Material investigated with used histological investigation also. It's conducted through thoracotomy's hole. And who is the best diagnostician? This is pathologa-anatom. Thank you for your attention. I finished today's lecture. Did you listen me? Right, please. Students, anybody listen me? Right. Okay, if you haven't questions, I can finish today's lecture. See you later. Goodbye.